Well, hello everyone. Thanks for having me here. As you heard, I work for the New York Times. I've spent the last year and a half writing a series called Pain Till It Hurts, and at this point, my husband, my kids, my friends are all sick of hearing my diatribes about healthcare, so it's great to be invited to a place like the Mayo Clinic where people are still interested in hearing what I have to say. So anyway, I want to start off by introducing you to a little video that I made of Renee Martin. She was 32 when this was taken last year on my iPhone, and she was 7 months pregnant. Lori, can you run the video?
We got pregnant, and it was sort of after we'd stopped trying, but we were so elated. And we called the hospital, and I said, well, can you give me ballpark? I think the range was from 4,000 to 45,000. I don't know what to expect in any way, but I also don't want to make choices based economically instead of what's best for me and my baby. And so that's really scary. Even yesterday, I was just talking to my mother because we started childbirth classes, and they're saying, oh, you can use the bathtub or you could use the ball. And my mother says, totally innocently, well, how much does the bathtub cost? If you get an epidural, how much is that gonna cost? And I don't wanna think about that in my childbirth. I want to do what's best for the baby. The hospital, they're really trying to help us, and the doctors are really wonderful. It's just, we're trying to make it work in a system that doesn't work.
Okay, well, thank you, Renee. I think she says it so nicely. Patients in this country are trying to make it work in a system that doesn't work. And the good news for those of us here in this room is that there's plenty of room for improvement and innovation, and that's why we're all here. The ACA took a small step towards solving problems like this one in that Renee was insured when she made this video, but her insurance policy didn't cover maternity care. That's no longer legal in the United States. But there's still a lot to be done. So I want to tell you a little bit about how Pain Till It Hurts, the series, was born. I'm the kid of a doctor. As you heard, I trained in internal medicine and practiced in an emergency room in New York City for a number of years in the late 80s and early 90s, around the time of the beginning of the HIV/AIDS epidemic. Ironically, I'd always loved writing and came to the Times in the early 90s to write about the Clinton health reform effort. You all know what happened to that, but I stayed. At the time, though, I'd worked in an emergency room for about 4 years, and I felt like our healthcare system wasn't serving a lot of people I was seeing, particularly the poor and disadvantaged. Now I'm here, standing here 20 years later, and I have that same feeling, but now I feel like our system doesn't really serve anyone very well. So that's why we're here. Anyway, after the Clinton reform failed, I took a bunch of overseas assignments for the New York Times, not covering healthcare. I was away for about 10 years. I experienced a lot of other health systems. I had root canal in Hong Kong, stitches in Rome. I had a broken bone in my hand treated in Sweden. I know it sounds like a disaster, but it was really a wonderful decade of my life. But when I returned to the US in 2007, I was looking at US healthcare with new eyes. Augmentin, which I'd remembered coming in when I was a resident, and costing $35 for a prescription, which we thought of as really expensive. I came back, my kid had an ear infection, and it was over $100 for Augmentin. Likewise, I remembered vaccines as being really cheap, and yet when my daughter went to get an HPV vaccine, it was $500, and I fractured another little bone in my other hand and went to get my ulnar gutter split put on at the Hospital for Special Surgery and came away with a $7,000 bill. But of course, the final straw for me, the straw that broke my camel's back, was I was 50 when I came back to the United States, and I needed a screening colonoscopy. So I know not a lot of talks start with a talk of the speaker's screening colonoscopy, but here goes, because this was really a defining experience for me. I knew that healthcare had changed a lot in the US during the time I was away, and so I went to the health benefits manager at the New York Times and said, how do I get one of these in network? And she gave me a list of places in New York City that would do screening colonoscopy in network and with no charge to me. And I saw on that list was Memorial Sloan Kettering Cancer Center, and I thought, great, you know, cancer screening, cancer hospital, I'm going to go there. And I arrived on the appointed day, and I was a little bit surprised. I'd done part of my medical training at Sloan Kettering, so I knew the place, and I had pretty fond memories of it. But I was surprised when I got there to find that I was getting a hospital wristband, I was getting an IV, I was getting a surgical bonnet, someone was taking away my clothes, I was put on a gurney, and basically wheeled into what I knew to be an operating room. I mean, there were nurses in scrubs running around, anesthesiologists, and I was a little concerned that this might be kind of costly doing it this way, but you know, I got my dose of propofol and everything evaporated very quickly, and I woke up 2 hours later. I was happy, you know, I had a clean bill of colon health, and I really didn't think much more of it until about a month later when I got my explanation of benefits. Now, I'm a kind of healthcare wonk, so I actually look at these things. And I was pretty surprised to see that Memorial Sloan Kettering had charged me charged my insurer over $12,000 for that screening colonoscopy. And I think I was even more surprised that my insurer, in the name of bargaining down the price for me, you know, to help me out as a patient, had paid out over $9,000. Now, my contribution was zero, so I guess I should have been happy, but I wasn't. I was really distressed by this. So when the issue of the ACA came up during the 2012 presidential campaign, I asked my then managing editor whether I could do a series on costs and pricing in U.S. healthcare, and he told me to go ahead. My idea in this series was not to talk about, and I know these things are all important, but I wasn't going to focus on the $500,000 cancer drug or the $2 million ICU stay at the end of life. I'd read a bunch of those stories that were really, really compelling and good tales, but I think the reaction to most readers of those is, wow, I hope I don't get that cancer, and I'll make better decisions at the end of life. Instead, what I wanted to focus on are all the ordinary procedures that cost so much more in this country than they do in other countries. And I wanted to find out, you know, where does the money go? Why are they costing so much? How could we do things better? And, you know, you see here, I guess you see there on, you know, just some examples of the kind of disparities we were talking about and looking at in Paying Till It Hurts. I should point out that the first one, the colonoscopy example, is low because that doesn't include an anesthesia fee. I want to tell you before I start giving you a wildfire tour through Paying Till It Hurts that the reader response to the series has been phenomenal. The first article had 15,000 comments. I like to say that is more comments than Nate Silver got on Election Day, which is our metric of success at the New York Times. Every person who you'll see and meet in this series is someone who commented on an earlier story and offered up their experience and their bills. And I think the comments are a wonderful resource to people interested in healthcare reform because they're kind of a catalog of all the ways in which this system isn't working for patients. And remember, these are New York Times readers. These are people who are by and large well-insured, well-educated, good at troubleshooting healthcare problems. They're not going bankrupt, but they're beyond frustrated. I mean, John mentioned this already, which is why they sacrifice their time and their privacy to be involved in this series. I mean, usually as a healthcare reporter, you have to kind of drag patients out and say, please, 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 are you willing to have your picture in the New York Times to talk about something as personal as healthcare? My experience in this series has been the total opposite. I always like to tell people about my favorite patient, Lee Higman, who is a 71-year-old retired grandmother in Pocatello, Idaho, who contacted me because she was pissed. And she was pissed because she had been ordering her Vagifem estrogen tablets from Canada, because in Canada they cost 1/10 the price, exact same pill as they do in the United States. And she was pissed because she had been contacted by FDA enforcement agents at Los Angeles Airport, where her Vagifem tablets were impounded and destroyed as illegal contraband. And she wanted her story told. Not many people in this country want to talk about their Vagifem tablets on the front page of the New York Times, but she did. So anyway, let me give you a lightning fast tour of Paying Till It Hurts. We started with colonoscopy. Now you know why. Our first patient was Deirdre Appellatter. She was a commenter on an earlier story. And what I learned from the story about colonoscopy is how the facility fee and the anesthesia fee really bulk up our costs. Here's where Deirdre had her screening colonoscopy. By the way, it was the third she'd had in 10 years. It's not clear why. Her colonoscopies were all normal, but she'd been advised to keep coming back. This is just outside New York City in Long Island. As you can see, in one building there's Gastroenterology Associates and the Long Island Center for Digestive Health. They're in fact on the same floor, and they are in fact kind of owned by the same people. If you get off the elevator on the third floor and go to the right, you're at Gastroenterology Associates, which is a group practice. If you get off and go left, you're at Long Island Center for Digestive Health, which is a freestanding surgery center largely owned by the doctors in Gastroenterology Associates. 10 years ago, if you'd had your colonoscopy there, you would have gone to the doctor's office, gone to a procedure room. He or she would have administered the sedation, and you would have gone home. Now you go to the surgery center, and this is what the bill looks like. Okay, so this is Deirdre's colonoscopy. It totaled about $6,400. You can see there's a facility fee of $29,100, an anesthesia fee of $2,400, the gastroenterologist of $1,075, and that looks like a pretty good deal until you realize that the gastroenterologist is also getting the facility fee. Doing it in a surgery center or in an operating room, as I had mine, allows many more kinds of charges to be added. If you look at how that has led to like wide variations in charges for colonoscopies across the country. This is the highest price in various markets. You can see Baltimore is a relative bargain at about $1,900. New York, where I got mine, is the top, which is $9,000. I can tell you, because I spoke to a lot of European doctors, when I asked them what their facility fee was, they went, huh, what do you mean? You can't do a colonoscopy without a facility. And in Germany, looking at their national price list, which is not a nationalized health system, but a regulated health system, the price for colonoscopies is about $300. So then we moved on to pregnancy. There's Renee again. In other countries, pregnancy is considered a kind of holistic experience. Here it's highly, highly unbundled now, priced item by item, which is why Renee and her husband had to be such good shoppers. These are Renee's charges: hospital charge of $20,000, obstetrician, you can read through them, item by item by item by item. And I want to point out that her father-in-law, Mark's father, her husband's father, is chief of pediatrics at the hospital where they delivered. So this is probably a best case scenario. I also spoke in the course of this series to a Dr. Marguerite Duane, who's a family practitioner in Washington, D.C., who was so fed up with the unbundling of pregnancy charges that for her third child, she thought she could beat the system. What she did was she arrived about 30 minutes before she delivered, had natural childbirth, brought her own heating bed, her own Motrin. She took her son after delivery and said, he's staying with me in my room. And she discovered, you know what, that she couldn't beat this system, that the delivery still cost, I think, $7,000 because she was charged a rooming in charge since she didn't put Isaac in the nursery. So no wonder then that, as you can see, our charges for childbirth are so much higher than they are in the rest of the world. The third story, I'm really racing here because 18 minutes is not long enough for me, is about Michael Chopin, who is the best medical consumer ever. Mike Chopin had a bum hip because of an old sailing injury, so although he was insured, he had to pay out of pocket for his hip replacement. He was a really good consumer. He found the hospital he wanted and priced it out, found the surgeon he wanted and priced it out. He even, doing some research, figured out that he wanted a particular kind of Zimmer hip and found somebody who knew somebody who arranged for him to get that hip wholesale for $13,000. Turned out he added it up. It was not doable for him financially, and he found a hospital in Belgium that would do it. So I want to show our second video here. This is comparing two surgeries, one in the US and one in Belgium. Mike Chopin's in Belgium. This is Michael Chopin. The other patient is Susan Foley, who had a knee replacement in San Francisco.
I needed a hip replacement, and I started looking into what it cost to have it done.
it came to $112,000, $112,317 total charges for the hospital.
I'd heard about having surgery overseas. Basically, the price was $13,660 for everything. The surgery, the rehab, the flight over and back, 2 people, crutches, medication to take home with me, and everything.
This is not the prosthetic, this is not the anesthesiologist, this is not, anybody who actually did anything. This is just the hospital bill.
Total cost of hip surgery in Belgium, including everything, cost just about $600 to $700 more than the wholesale cost of just the prosthetic device in the United States.
Lori, we can stop that there.
The good thing about my knee surgery was getting my mobility back. And it
Okay,
enabled me.
great, thank you. So why do hips cost so much? When I started looking at bills, the biggest single line item on the bills was the prosthesis itself, the artificial joint. And when I started calling around to the joint makers to see why that was, I noticed that I was always calling the same area code. And it turns out that 3 of the 5 big joint makers in the world that make almost all of the joints implanted in the US and most of them in Europe are in a little town called Warsaw, Indiana. There's a population of 20,000. A mixed marriage in Warsaw, Indiana, which I visited, is when one person works for Biomed and the other works for Zimmer. It's almost like you don't need active collusion. When there's not enough players in the field, there isn't really competition. They look at each other and go, I'm okay charging $30,000, $20,000 for a joint. Are you? Yep, that's fine. It works out for everyone. Also, they have a lot of buy-in from surgeons, because surgeons during residency get to know the rep from one of the companies. They get familiar with one of the systems. There's even a tech from one of the companies in the room during most surgeries in the United States. That makes it very hard to go to generics or for new companies to break in, and that really holds the price up here. In Belgium, the government negotiates a national price for different kinds of hips. There's a whole range that are available to surgeons, but the kind that would have been $13,000 in the US is about $4,000 in Belgium. Okay, next up, we have pharma pricing. I wanted to do something on pharma because we got so many complaints about it. So I want to show you a little, well, actually, let me step back. I wanted to focus on asthma because so many people have it. Also because in early interviews, a political blogger in DC, John Aravosis, told me that he financed his summer vacations to Paris each year by buying his Advair there. It's a real first world problem. Now, why did that work? Let's see the next, it's a multimedia. Okay, can you push start with the first one, start with Qvair. These are manufacturers' suggested retail prices. Same medicine. Okay, let's do Advair. We'll see how John financed his vacation. Rhinocort, we'll skip over Augmentin, even though. And actually, let's do Augmentin. Let's stick with that. Thanks. And again, these are same drugs, manufacturers' suggested retail prices. So big difference. I'm going to keep talking, but why don't you run the call, Chris, just so people can get a look at that. So why does that happen? I mean, part of it is that we don't negotiate prices nationally at any level. It's one by one. The second is we allow for repatenting as drugs go through slightly small reformulations. The little asthma inhalers, when they changed the propellant from CFCs to HCFCs to something else, they were allowed to repatent, which meant my $10 inhaler was now over $100. We allow drug companies to do what we call pay for delay. We trust in generics to bring down prices, but brand manufacturers are allowed to pay generic manufacturers to not compete. I'm going to have to really scoot through now. I wanted this. We'll stop at this one. Next up was hospital pricing. What better than stitches in the ER? I heard from a lot of patients on this one. The prices range from between $2,000, that was just glue in a wound, to $46,000, where a plastic surgeon was called in to sew up a shallow cut. 1/3 of the people I heard from were so upset by the prices that they saw that they took out their stitches themselves at home rather than pay a removal fee. 2 were at California Pacific Medical Center, which was a great opportunity for me as a journalist because California is the one state that requires hospitals to file their master price lists or Chargemasters. You can get a sense of why prices were so expensive. You probably can't see that, but you can see that CPMC charges about $3,000 for a CAT scan. That little tube of glue was going for about $300. So I always wonder why more states don't require hospitals to file these things. The cost of a hospital A is far more in the United States than in other countries. And the one other thing that we don't focus on very much as we think about the cost of hospitals is what hospitals look like in the United States compared to other countries. This is Mike Chopin's hospital in Belgium, where he got a first-class hip replacement. It doesn't look like many hospitals in the US. I would encourage you all, can we just show for a second, and people can do it at home? We made up a quiz that I encourage you all to take. It's called, Is This a Hospital or a Hotel? There are a bunch of hospitals in the US. You can scroll down quickly. I'll let you vote. You'll see it's really hard to tell which is which. That certainly drives up pricing. My daughter, who just graduated from Princeton, had a $42,000 emergency room visit at a brand new hospital in Princeton that is gorgeous. The New York Times just did a wonderful design story about. But was it worth a $42,000 ER visit? I don't think so. It was for stomach pain. She was back taking a final 4 hours later. So anyway, I encourage you all, if you have time, to look through our series, to look at all the other factors. There's one on the high price of diabetes equipment that really is, the business model is the same as my HP printer. The printer's pretty cheap to buy, just as the glucometer's pretty cheap to buy, but those cartridges that run out all the time are really expensive. Those paper test strips, they are made to only go with your brand of glucometer, no generics, and they are costing patients about $150 a week, and insurance doesn't cover them very well. Likewise, some of the procedural specialties, dermatologists, we did a story on Mohs surgery and how expensive that's become for basal cell carcinoma. Even though basal cell carcinomas, most of them can be treated in a half a dozen ways very effectively. By a cream, by just scraping off, by radiotherapy. I mean, there are so many options that patients are not told about. So anyway, that's where we stand now. I encourage you all, I assume I get to inaugurate this conference because I can spout off all the problems. Now I'm going to sit back and listen to the solutions. I think I've seen every bill at the New York Times and out. I encourage you all, I'm going to skip through, there's our Mohs surgery, yearly diabetic supplies, look at that. The price of required childhood vaccines, look how much they've increased. Vaccines are no longer pennies apiece. And I will tell you about our new Facebook group, which I'm encouraging you all to join. We've just started about a month ago, and I'm trying to get people who are thinking about these problems to join in the discussion. And I hope it contributes to solutions, because we certainly need them. Patients are certainly hurting out there. Thank you.
So let's talk about a couple of things.
Yeah.
It seems one of the backstories here is the way in which you tell the story. I mean, the style of journalism here is part of the disruption, in that you're using techniques that encourage people with stories to really get involved. How did you design the storytelling?
Well, I had a list of stories I thought I wanted to tell, and basically we started with a little blog post that said, it was about a study in the Annals of Internal Medicine where a college student called 100 hospitals and trying to price out a hip replacement for a fictional 62-year-old grandmother who didn't have insurance but could pay. And not to anyone's surprise in this room, most hospitals could give her a price. And so we put a little box at the bottom saying, if you had any experiences of healthcare pricing that you want to share with us. And people, I mean, there was a flood. In 3 hours, we had 515 comments, and I was off and running. And so I don't think of this, you know, most of journalism is we give you something. This has been a real kind of revolving door. I've gotten as much as I've given.
Do you think that the consumer base in healthcare is, and that your series is some evidence of this, is becoming empowered? That we're shifting from a privacy siloed model of I keep my data close to my chest to a I want to tell people because I really want to figure out if I'm getting ripped off compared to my neighbor?
Yeah, I think for a long time, first of all, what's happening is that people, because of rising deductibles and co-pays and out-of-network expenses, people are experiencing a lot more of these costs. So those explanation of benefits that most people would have filed away or looked at and said, whoa, that's crazy, but I'm not paying it. They're caring more about those. So I think there's a lot more engagement on the part of consumers. And there's not, you know, at some level, what was irrational is that people never talked about pricing in healthcare as if it was irrelevant. You know, when I talk to doctors' groups, I often say, you know, it's your responsibility to think about price because there is a price. You know, why do I know the price of a toaster at Target, but my doctor doesn't feel like he has to know that the MRI in the hospital will cost $5,000, but the one down the block by the same doctor will cost $500? I think, you know, we're losing a lot in this country for not thinking about healthcare pricing.
You said at the beginning of your talk, the decade in which you were outside of the United States experiencing some of this was a very pleasurable decade. You mentioned Stitches in Rome. That sounds like a movie title. Did you have Stitches in Rome?
I had Stitches in Rome, and I went to, I remember I went to the Gemelli Hospital, which is the Pope's hospital, so the best hospital. I actually had, it was facial stitches, so it cost me slightly over $100 with a lot of apologies. And I just realized that, you know, these are not, and now I'm seeing bills for $3,000 for a little finger cut. I mean, I wanted to call this series "You Don't Get What You Pay For," you know, which I think we don't as a nation, and I think that's a problem. And clearly, the patients who saw these bills, because now a lot of people have 20% copays for ER visits, were shocked, appalled, often had trouble paying. You know, it wasn't like a little inconvenience. It was, holy cow, now I don't have that $700 to go on vacation.
You're not an economist, and I think we're going to talk in this session about market-based solutions, which are often referred to in healthcare reform discussions, particularly in Washington. But just from your standpoint as a doctor who's also a sort of an economic bystander to the system here, you're not a policy wonk so much, notwithstanding what your family thinks.
Right.
What do you think is going on here? We think of markets as what the consumers want, not what they will accept in terms of the price that's given them. Is there a tension in healthcare right now between what consumers actually want and what they will accept in terms of a high price?
Yeah, I think there is, because we often don't pay a lot of it. Also, I think healthcare is really funny. First of all, you don't know a price, right? So how can you be a good consumer? I mean, look, Renee Martin, she tried to be a good consumer, and the price she was given was between $4,000 and $45,000. How can you be a good consumer if you can't get that information? And I don't buy this idea that it can't be given. I mean, it can be known. I always say, you know, I go on Expedia and I book a fly hotel and drive package. They're all parts are discounted, but I can know what it costs. The other thing is, I think, and I say patients are partly responsible too, because we look at the wrong things. It makes me a little nuts when I have colleagues who go into hospitals and go, oh, it's such a great hospital, there's free coffee in the lobby. You know, patients, we tend to look at the wrong things as patients when we really should be focusing more on results, which are, of course, much harder to get. And that's part of the problem. So, and hospitals are smart. They know that patients want, you know, nice views. Well, that's nice, and I'm all for nice views and all for, you know.
But is it patients that want nice views, or is it just dumb Americans who it's a hotel? Wow, I'll pay $30,000 for my colonoscopy.
Right. Well, it's kind of what we've gotten into our heads as this is what's necessary and this is good for us. You know, Mike Chopin, when he pulled up to that hospital in Belgium for his hip replacement, his father had died at New York Hospital the year before, and he pulled up and he was like, oh my God, I can't go here for a hip replacement. It looks scary. You know, there's no Starbucks in the lobby. And he had a wonderful experience. He said the people were wonderful. Yeah, the chairs may have not been as comfortable, but you know, I think we need to refocus American healthcare generally from the patients to the providers on what's really important for healthcare, which is delivering good health.
Elisabeth, thanks so much.
Sure. Thank you.